Good evening, everyone on the East Coast, and good afternoon if you're on the West Coast. We're just going to let everyone come in from the virtual waiting room, and we'll begin our program here shortly. Okay, I think we're going to go ahead and get started. Dr. Hansen-Lindner, Dr. Tobe, you ready?
Yes.
Terrific. Terrific. Well, let me welcome everyone who's joined us this evening. Again, good evening or good afternoon, depending upon the time zone you're in. My name is John Griffin. I'm the Senior Director for Professional Education and Training for Gynesonics. I want to welcome you to our Sonata Insights webinar titled The Sonata Procedure for Uterine Fibroids, a discussion on patient selection, fertility, and pregnancy with our faculty, Dr. Leslie Hansen-Lindner, and also our own Dr. David Tobe, Senior Vice President of Medical Affairs. First off, Dr. Hansen-Lindner, Dr. Tobe, again, thank you both for hosting with me and presenting your insights and experience with us on this webinar. It's great to have you here this evening. I'm going to go ahead and turn it over to Dr. Tobe to begin our discussion in just a minute, but I wanted to thank all of you for joining us this evening. We have approximately 20 participants on the line with us, which is terrific. This will be a great opportunity to have an interactive exchange with these presentations that Dr. Hansen-Lindner and Dr. Tobe will be presenting to you. We certainly know you've all had a full day, so we are grateful you've joined us this evening. But we know you'll find this interactive discussion with our faculty very valuable for your practice and, of course, overall Sonata procedure knowledge. So with that, just a couple reminders. Please feel free to make this an interactive session. I know we're all used to our virtual meetings throughout the day, but we want you to feel free to ask any questions by using the chat function on your screen to type your question, or you can raise your hand by clicking the small hand emoji that you see there at the bottom of the screen, and we will ask you to go ahead, and I'll make sure that I unmute you. So please feel free to ask questions, and we'd encourage you to turn your camera on as well. If you feel like it, we'd love to see your face. And again, we'll go ahead and get started. And so without any further ado, I'd like to introduce our faculty for this evening's program. Dr. Leslie Hansen-Lindner practices in Charlotte, North Carolina at Atrium Health and is currently the chief of the Department of OBGYN at Carolinas Medical Center. She received her MD and training at the University of Pennsylvania and has practiced at Atrium for over 25 years. She is a clinical adjunct professor at Wake Forest University and is active in medical student education. Dr. Hansen-Lindner's clinical interests focus on advancing minimally invasive and hysteroscopic procedures for the management of AUB and fibroids. Dr. Hansen-Lindner is a co-author of the Journal of Clinical Medicine article, Transcervical Fibroid Ablation, Update on Pregnancy Outcomes. Dr. Tobe is our Senior Vice President of Medical Affairs at Gynesonics. He received his AB and MD degrees from the University of Chicago. He completed a fellowship in pelvic surgery at Graduate Hospital and also served as an attending physician at Pennsylvania Hospital, where he held faculty appointments at both Thomas Jefferson University and the University of Pennsylvania. He is a fellow of the American College of Obstetricians and Gynecologists, a diplomat of the American Board of Obstetrics and Gynecology, and an associate member of the Royal College of Obstetricians and Gynecologists. A laparoscopic and pelvic surgeon with special interest in providing alternatives to hysterectomy, Dr. Tobe has been a faculty member and speaker at various conferences and has authored a chapter on the fundamentals and application of radiofrequency ablation in gynecology for a surgical textbook, and also serves as an editor for 2 professional journals. We're very fortunate to have you again both with us this evening. Thank you for being here. And with that, I'd like to go ahead and turn it over to Dr. Tobe to begin our discussion. Dr. Tobe?
Thank you, John, and welcome, everyone. I wanted to speak just very briefly about fibroids and pregnancy, including some of our latest data relating to transcervical fibroid ablation. Next slide, please. So one of the questions out there has always been, do fibroids cause infertility and or miscarriage? And so the general opinion, if you ask a whole bunch of gynecologists out there, is that probably fibroids that indent or abut the endometrial cavity, so FIGO fibroid types 1, 2, 3, and 2-5, which are transmural fibroids, and maybe some intramural fibroids could cause infertility and miscarriage. The evidence for type 3 fibroids causing infertility is probably strongest for assisted reproduction, and probably such fibroids interfere with blastocyst implantation. And the common belief is that cavity-distorting fibroids do cause first trimester miscarriage. Next slide, please. So what's the evidence for any of this? So if we turn to the American Society of Reproductive Medicine, they have a very different tact looking at the evidence that's actually out there. And they've concluded that there's really insufficient evidence to say that fibroids cause infertility, regardless of whether or not someone is undergoing assisted reproductive technology. Doesn't matter if fibroids are large, small, where they're located, or how many fibroids. That doesn't matter. Fibroids may not increase in early pregnancy loss, or may not increase a difficulty with getting pregnant. There is fair evidence, however, that doing a hysteroscopic myomectomy for submucous fibroids improves clinical pregnancy rates. But there's also insufficient evidence to say that hysteroscopic myomectomy reduces the probability of early pregnancy loss in women with infertility and a submucous fibroid. There also is a really good systematic review and meta-analysis 7 years ago from folks at Vanderbilt University, where, and I'm quoting them, leiomyoma presence was not associated with increased risk of spontaneous abortion in an analysis of more than 20,000 pregnant women. Failure of prior studies to adjust for confounders may have led to the common clinical belief that leiomyomas are a risk factor for spontaneous abortion. So I think while most of us do believe that in some way, shape, or form, fibroids may cause infertility, the evidence is really lacking. Clinical experience is what probably guides us more than the evidence in literature, but there's pretty good evidence that fibroids don't cause miscarriage. So that's at least good. Next slide, please. Sorry, next slide. There you go. So there are a lot of hypotheses for how fibroids could cause infertility. None of these are proven, but most of these have to deal with implantation failure in some way, shape, or form, or some effect on not being able to conceive in the first place. Next slide, please. So what about transcervical fibroid ablation and pregnancy? And transcervical fibroid ablation is the procedure that is performed by the Sonata device, the Sonata system here in the US and also in Europe. So if you look at our current labeling, whether in the United States under FDA or the European Union under CE mark, the labeling only says one thing, namely that the safety and effectiveness regarding fertility hasn't been established and the potential risks are unknown, but that as a uterus-conserving hysterectomy alternative, transcervical fibroid ablation does not eliminate the possibility of pregnancy. That's it. There are no warnings in our labeling, and a woman having a fertility desire is not considered a contraindication to treatment with Sonata. In fact, we have had normal pregnancy outcomes reported. We started with some case reports, mostly in Europe, and then in 2021, there was a very large case series at the time of 36 pregnancies with very good outcomes. This was based on our experience, with one exception, in Europe, because that's where transcervical fibroid ablation really got its start. Next slide, please. I also want to mention that in terms of intrauterine adhesions, we used to get a lot of questions about this early on. And while some people did their own anecdotal second look hysteroscopies and didn't find any adhesions, Gynesonics did want to study this formally. So we did something called the open trial. This was the only clinical trial looking at adhesions anywhere that didn't have the adhesions evaluated by the investigators themselves, but by 3 independent reviewers who had no ties to Gynesonics at all. So that eliminated a whole lot of bias right there. At the end of the day, there were 34 pairs of baseline and second look hysteroscopy videos that could be evaluated by these independent reviewers, and they didn't find any adhesions, and that's great. But I come from a pretty strict academic background, and I do want to point out, in all fairness, this was not a powered study. Certainly, if we had looked at maybe 100, 200, women after treatment with Sonata, maybe somewhere along the line there would have been an adhesion or two. But I do want to point out that we included 6 women who had opposing fibroids, so fibroids really close to one another. And from the literature, there's about a 78% risk of intrauterine adhesiogenesis if someone were to do hysteroscopic myomectomy on opposing fibroids. Those 6 women with opposing fibroids who were treated with Sonata didn't develop adhesions either. So obviously the study wasn't powered. It can't prove a negative, but the risk of intrauterine adhesions after treatment with Sonata, according to the authors of the study, appears to be minimal. Next slide, please. So on the left, you see the paper from 2021 of 36 pregnancies, really good outcomes after treatment with Sonata. But I do want to call attention to a more recent paper that Dr. Hansen-Lindner, Juliet Schmidt-Losberg in Zurich, and me co-authored. And this involved 89 pregnancies. So this is actually the largest case series out there of pregnancy outcomes after any fibroid ablation treatment, including focused ultrasound. Up to now, the largest that was out there was a 54-patient study, or a 54 pregnancy study, co-authored by Rabinovich and colleagues. That dates back to 2010. So now transcervical fibroid ablation has essentially overtaken that significantly. So I'd like to tell you more about that. Next slide, please. So the way we got this data is through several sources. In some cases, these represented patients who were in fact enrolled in clinical trials, meaning we had ready access to the data. However, the vast majority of patients were not treated under any clinical trial protocol. So that represents post-market usage. And the way we have that data is because the patients were willing for their physicians to provide the anonymous data. Everything is anonymous. And the physicians heard of this, or in some cases, they did deliveries themselves. Dr. Hansen-Lindner is one of the people who contributed a significant number of pregnancies to this database. So that's how we have this. Next slide, please. So what's in the paper? Essentially, 72 women got pregnant at least once after treatment with Sonata, and I stress at least once. 26 women had never been pregnant whatsoever. 46 women were NOEPs, so they either had never been pregnant before or they had never had a delivery greater than 20 weeks. 12 women were enrolled in clinical trials, as mentioned, but 60 women were treated post-market, so not in any clinical trial. The mean ablated fibroid diameter was just over 3 centimeters, all the way up to 8.4 centimeters as the largest fibroid that was treated. The most frequently ablated fibroid type by far were transmural fibroids, FIGO type 2-5 fibroids. The next largest were type 3 fibroids. Next slide, please. So I mentioned we've had 89 pregnancies in this paper that got published, 55 deliveries among those 72 women. 8 women got pregnant more than once, 11 women conceived via assisted reproductive technology, 10 pregnancies were ongoing as of the time of writing. One patient was totally lost to follow-up, but did deliver. We just don't know by which route. We've had 19 vaginal deliveries, 35 sections, all but 6 of which were primary sections, all for the usual obstetrical reasons that we know very well, like failure to progress or breech presentation. But the most common reason by far for C-sections was patient request, primarily because in some countries, notably Germany, they do that at a very significant rate, unlike here in the US. We did have some miscarriages, but the majority of the miscarriages, 10 of 18 miscarriages, occurred in the same 2 patients, one of whom had antiphospholipid syndrome, a known risk factor for recurrent pregnancy loss. The other one was never evaluated, but she started off before she was ever treated with Sonata, having had 16 miscarriages in the first trimester. Very unfortunate situation. And I do want to mention that one of these 2 women, the woman who had antiphospholipid syndrome, did actually have 2 term deliveries after treatment with Sonata, in addition to a total of 6 miscarriages. Those 2 pregnancies, not surprisingly, were both complicated by pregnancy-induced hypertension. In one case, HELP syndrome, and the other just garden variety PIH. Very importantly, there are no uterine ruptures, no instances of placenta accreta spectrum, and no intrauterine fetal demises. Next slide, please.
Dr. Tobe, we had a question come in. I think it might be
Yes.
appropriate here where we
Sure.
are in your presentation from Dr. Lewis. Any data on the timing of the pregnancy following Sonata?
Yes, we're going to get to that momentarily, if we could just hold that. Great question.
Terrific.
Next slide, please. So as I mentioned, we did have some C-sections for this, but again, none of the patients so far were actually being sectioned because of prior treatment with Sonata. They were being sectioned in some cases, certainly because of prior myomectomy, and in one case, actually because of a prior laparoscopic fibroid ablation procedure, in addition to myomectomy. Next slide, please. So this is, as I mentioned, this is the largest case series of pregnancy outcomes after any hyperthermic fibroid ablation modality. But I do want to caution that this is still a very limited data set, even if it's the largest. There could be pregnancies out there we don't know about with amazingly normal outcomes. There could also be some pregnancies out there we don't know about with not so good outcomes. So it's very important that this be individualized. There is no right or wrong answer here. As I mentioned, there's nothing in our labeling that says this is absolutely safe in women who want to get pregnant, because it has not been established. Certainly in terms of uterine rupture risk, we would have to have had hundreds of deliveries before, statistically speaking, even seeing one uterine rupture, if we're at the same level as, say, the risk of uterine rupture after myomectomy, which is about 0.5 to 0.7%. Next slide, please. So I do want to mention one advantage of Sonata is that we have an ablation guide, and we actually show where the ablation is taking place. You see that red ellipsoid, for example. Physicians can choose, if they want, to constrain the ablation to lie within the pseudocapsule of the fibroid, so as to avoid collateral ablation of myometrium and or endometrium. As far as the timing of pregnancy, in terms of that question, so we have not formally studied it. We don't have last menstrual period data on most pregnancies in our database, but we do have it for some. And the earliest documented pregnancy was about 3.1 months after TFA, when I wheeled it out. Small numbers of patients who conceived, 3 months later. So it's really hard to say. So I think we really don't know. I think certainly for assisted reproductive technology, most people are going to want to wait at least 3 months for the cavity to normalize, because it takes about 3 months for most fibroid volume reduction to take place, whether you ablate the tissue, use a GnRH analog, or embolize the tissue. That's just how soft tissue responds to all of that. And as far as the optimal route of delivery, that we have no real idea for that, for any fibroid ablation technology. There have absolutely been vaginal deliveries reported for everything, but we don't know, based on the numbers, if that really is truly the safe way to do it. Next slide, please. This is just some of the references. There's a lot of literature out there right now on RF ablation and pregnancy, in particular, transcervical fibroid ablation and pregnancy. Next slide, please. This is our intended use statement. Next slide, please. So, Dr. Hansen-Linder, I did want to just start off by asking you, as you start off, what was it about Sonata as a practicing physician in North Carolina? What was it about Sonata that you felt enabled you to have that sort of discussion with your patients around whether or not they might be able to get pregnant and have normal outcomes after treating their fibroids with Sonata? And what sort of things were your patients curious about?
So I would say my comfort level didn't start right away. It developed over time. And I would say there's probably two pathways of this discussion. So the background on how I was introduced to Sonata was from a reproductive endocrinologist. So my first contact and discussion and understanding about it came from someone who had the understandings of fertility and assisted reproductive technology and the impact on the endometrium. But there was really never a discussion about pregnancy until probably after about my 10th or 12th case. And I started having the light bulb go on just how it may be very beneficial, especially as I compare it to my laparoscopic myomectomies, open myomectomies, et cetera. I felt like there was less tissue damage, less myometrial damage with Sonata than there even was with myomectomies. So as I treated more and more patients, got a better understanding of how the uterus responded, and my comfort level with the device and the protection of the myometrium grew, I started considering offering it to women who decided they wanted to be pregnant. And there's a lot of women who are in their later 40s who would like to be pregnant, but don't necessarily have a plan of action in place, or maybe even have health conditions that might limit their ability to be pregnant. We have a lot of patients that visit us for myoma surgery who have a very different pathway than perhaps a 23-year-old who has a 3-centimeter type 3, type 2-3 fibroid and significant anemia. So people who choose to want to be pregnant are probably, I would say, at different levels of wanting to be pregnant, if that makes sense, and being able to have a very good discussion with them about their desires and their goals. This data set really helps to be able to speak to all those women who want to try and conceive.
Thank you.
Terrific. Well, let's go ahead and we'll get into the second portion of our discussion this evening. Dr. Hansen-Linder, I'll go ahead and advance your first slide.
Thank you. So David gave you a lot of background about pregnancies that we've had who've undergone Sonata fibroid ablation. And I wanted to give you a bit more of a visual background about what Sonata does to the fibroid and how specific it is. So he showed you a picture of the ablation zone with the safety zone. And this slide shows 2 different uteruses on 2 different patients where the patient was already scheduled to undergo a hysterectomy 2 weeks after their Sonata procedure. And you can see in the left-hand photograph, the fibroid that was treated is pale in color. 2 fibroids that were not treated are untreated and their appearance still pink. But you can see how very specific the treatment zone correlates with the intended treatment, the tissue to be treated. So this shows you that you can have very specific treatment zones that spare the myometrium, that localize to the fibroid itself, so that you can be confident that you are only treating the tissue in the fibroid itself, so that that is where the thermal fixation occurs. Next slide. This is a pre-surgical appearance of a fibroid that measures 4 centimeters, and I drew it out just so that you could see it, since it's obviously a little bit easier to see on a live image. But it is a type 2/4 fibroid. It projects a slight bit through the endometrium and dents the endometrium. Next slide. And this is 3 months after the fibroid ablation. So you can see significant reduction in size, significant kind of straightening and lack of distension of the endometrium. And this is a really optimal fibroid treatment, but this gives you a good idea also of how the endometrium can be spared with the fibroid ablation. Next slide. This is another MRI image that looks at the initial pre-surgical treatment, the 3-month and then 12-month appearance of the uterus. Now, not all fibroids will respond in this way. This is, I would say, a more responsive fibroid. Typically, you would expect to see about a 50 to 60% reduction in size of the fibroids. And we have found, and I've found in the 4+ years I've been treating fibroids, that not everyone responds the same. And I'm still trying to figure out why that is, why some respond extremely well and why others don't. But this gives you, again, an idea of the precision of treatment that can result in normalizing the myometrium, especially surrounding the endometrium. Next slide. This is just another brief overview of the pregnancy data. The initial paper that was published had very encouraging results with 36 pregnancies. The next slide. And then the database that we're keeping and just reported with 89 pregnancies, which were now over 100, 105, I think. As of a couple of weeks ago, it probably is even higher at this point. But we have had a good database of information that has been cataloged, and we're trying to continue to add to that. So if any of you have had any patients that have conceived, we would definitely, with the patient's permission, like to have them included in the data bank, because more information is definitely helpful, not just good outcomes, but bad outcomes, so that we can advise and guide our patients who do desire a future pregnancy. Next slide. So when I counsel patients about future pregnancy, I share with them that the early studies for after treatment of Sonata showed that by MRI that there was no decrease in myometrial thickness and no visible abnormality in uterine integrity. And this is important as we think about those patients that may be at risk for uterine rupture. You're not going to know, like David said, unless you have 1,000 patients minimum to see if uterine rupture occurs. And the sort of subset to look at is through MRI after Sonata fibroid ablation to see if there's any effect on the integrity, and there appears to be no difference in the thickness. Intraperitoneal scarring with the open trial, and I've experienced that in patients who I've hysteroscoped a second time, is that we generally don't see any adhesions, even if we've done 3, 5, 7, 10 ablations. Often you don't even see where the needle has passed. And if you do see where the needle has been placed, especially if it's a type 3 or 4 fibroid, it's just a very small dot, far smaller than you would expect to see from a hysteroscopic resection using energy. In the emerging data it's kind of impossible to have a comparison of myomectomy versus Sonata because obviously two different approaches on the uterus, but there is some early data with RF energy as it compares to myomectomy that is starting to get published. Next slide. So I discuss the specific procedural risks. I discuss all of the possibilities that can occur with Sonata, which could be bleeding, hemorrhage, ongoing bleeding, suboptimal results, need for additional surgery, especially if it's a type 2 or type 1 fibroid, potentially needing a secondary hysteroscopic procedure. And then I always offer alternatives such as myomectomy, mini lap, laparoscopic, so that they know that those options, and I do discuss that myomectomy is the gold standard for treatment, but I give them the option of Sonata with the limited data set. And then discussing C-section or vaginal delivery, I generally would be conservative and for the most part recommend C-section, but with the data on uterine rupture with myomectomy being about as low as it is for a VBAC, if a patient felt strongly about pursuing vaginal delivery, I would just counsel them as I would a VBAC and be just very careful in my documentation. Next slide. So we've had 7 patients pregnant in our patients that have had Sonata. We've been doing it since 2020. And our first patient that delivered actually had a vaginal delivery. She had a previous Acessa with Dr. Lee out in California. And then 5 years later had Sonata. And we treated a large 8+ centimeter fibroid as well as several other fibroids. And she was counseled pretty strongly to have a C-section. She chose to have a vaginal delivery. She actually delivered at a hospital a couple of hours from here. And she did conceive with assisted reproductive technology. She had an uncomplicated delivery, a little bit of extra bleeding, but not even enough to quantify a postpartum hemorrhage. We had a patient shortly after that who had a history of a previous myomectomy, conceived with IVF. She had significant intrauterine adhesions from her myomectomy that we discovered at the time of her Sonata, and then went on to conceive very quickly after that. And we did a primary C-section at 37 weeks because of her previous myomectomy. We had 2 additional patients who had indications for C-section, either with previous C-section or with myomectomy, and then had 3 patients with miscarriages. One of those was a patient who had already had 2 previous miscarriages and had multiple submucosal fibroids. She has had a total of 30 submucosal fibroids resected by REI over the years. So her miscarriage is unfortunately not a surprise. So we've been feeling more and more comfortable with Sonata in patients who wish to become pregnant. And I do work closely with our REIs, and they refer patients who they think would be more ideal to have Sonata fibroid ablation as opposed to a myomectomy. And we work together to try and decide if they're good candidates for Sonata. So I have definitely seen my comfort level continue to increase. I'm still very protective of the endometrium when it comes to these patients, very careful about my ablations. We have recently started utilizing a smaller ablation zone, which has been a great help for our patients who are interested in future fertility, because it gives us a little more ability to keep a smaller size within the serosa and protecting the endometrium. So that's been a recent big improvement.
And Dr. Hansen-Lindner, since you talked about what's giving you more confidence in discussing Sonata with patients who might be seeking, fertility or pregnancy, you talked about less tissue damage, less myometrial damage, and you also talked a little bit about how you're presenting the Sonata procedure to your patients. You started to talk about this enhancement to the device. the question I had was, how has your patient selection criteria for Sonata evolved since you did maybe your first 5 to 10 cases? Has it changed? And if so, how?
Yes, it definitely has. In the beginning, I think, like probably anybody who has started using Sonata, you sort of are looking for that perfect patient, maybe 2, 3 fibroids that are type 3 to 5 fibroids, those kind of fibroids that make you comfortable, where you can say, this is a perfect Sonata patient. And in fact, that's kind of how I have started to classify my Sonata patients, patients who really are those kind of initial patients that you just love to see with fibroids that are causing increased bleeding, but they're not so numerous that they're, you'll be there for an hour and a half ablating. And I then have a kind of a second category of patients where I think that Sonata definitely can be done. It definitely can give them some improvement in their cycles, but I can't treat all of the fibroids. There's either too numerous or maybe larger subserosal fibroids where if I can make it an impact on their bleeding, that would kind of be that subset of patients. And then patients who there really is a better procedure for them, such as a hysterectomy or a myomectomy. But these are patients who maybe have had 2 previous myomectomies before, and their only option is a hysterectomy, or they just either really don't want another major surgery, or they need a bridge to a time when they can have the surgery that they really need. I found Sonata a great help for that for patients. And then I have a subset of patients that there's no way I can do a Sonata. I can't get the device in the cervix, either, from a fibroid that's posterior, that's sacculated, that's keeping me from being able to access the cavity. And those patients aren't that common, but they're common enough that I do have to turn some patients down.
Sure. Thank you. We actually had another question come in from the chat. And Dr. Lewis, thank you again for your question here. Have you used Sonata on focal adenomyomas or adenomyosis?
Yes, that's always the second most common question that comes up after the light bulb goes on and you start thinking about patients that you can use. First of all, can it be used in pregnancy? And secondly, what about adenomyosis? So when I first started treating adenomyosis with Sonata, it was that there was a fibroid and there was some clear adjacent adenomyosis. Now, adenomyosis is, it when you see it. You can identify it on MRI. You can see it sometimes on ultrasound, but intrauterine ultrasound really makes adenomyosis more easily visible because you're right up against the endometrium. So I have chosen to treat adenomyosis in those patients because even if you may not have seen it on a pre-op ultrasound, it more likely than not is contributing to the heavy and painful bleeding. I have treated now 3 patients, maybe 4, that have adenomyosis only, where there's no clear definable fibroids. But again, they know that the treatment that's the gold standard is a hysterectomy. There are some people who would do these extensive adenomyomectomies with defined adenomyomas. Diffuse adenomyosis is a little tougher, but this is an option to try with patients. And there is some data with transcervical treatment of adenomyosis. Most of it is out of Korea and China. But those studies are a little tough to extrapolate with because they don't really quantify the amount of adenomyosis. They don't have independent follow-up, like without an IUD or that kind of thing. But it certainly is something that you can talk to patients and treat that if you see it.
Thank you. No other questions in the chat, so we'll continue.
I think that is my last slide.
I think it is. Dr. Tobe, I'll invite you to come back on camera if you would please. And
I already am.
Perfect. And let us just take a minute here or so. If there are any other questions from our audience, whether you'd like to type those into the chat or raise your hand and we'll unmute you. we'll just give you a few minutes here. Anything else? Dr. Tobe, maybe any other comments you wanted to make as well, as we're maybe waiting for a question or two to come in?
Sure, I heard the excellent response by Dr. Hansen-Linder around adeno. I just want to make a more general comment, namely that there's really not a lot of clinical evidence out there relating to focused ultrasound or radiofrequency ablation or microwave ablation, for that matter, of adenomyosis. However, what does exist suggests, there may be some real benefits for any of those, but it still needs to really be studied more rigorously. Part of the problem, as I think we all know, is that there are different definitions for adenomyosis, different criteria, different definitions of what's extensive adeno versus localized adeno. Even the histopathology, sometimes pathologists come up with different diagnoses on the exact same tissue. So it's really hard to compare all these different studies. There was a systematic review last year from mostly people at the universities of Bern and Freiburg in Switzerland, looking at radiofrequency ablation, not Sonata, but radiofrequency ablation in general for adenomyosis. I say not Sonata because there are no clinical trials yet of Sonata specifically regarding adeno. And the results were pretty good, but the studies are all over the place in terms of how they define things. The two best studies I know of are from the same site in China, a team led by someone named Ning Hai. And one of the studies just used a single needle electrode inserted transcervically under transabdominal ultrasound guidance. And they treated both extensive as well as localized adeno, followed the patients through 1 year, and had, I think it was like about an 18% or so reintervention rate at 1 year, which isn't bad when you think about how most patients will end up getting hysterectomies automatically. But they did another study, also fairly robust. I think it was 81 patients, follow-up through 36 months, where they used the same needle electrode, but they also chased it with a Mirena, a progestin-releasing IUD, anywhere from 1 to 6 months out. And they cut that reintervention rate down. At 3 years, it was only 1.5%, which is really remarkable. So I think eventually we're going to see more studies regarding Sonata and adenomyosis. I know the folks in Bern are very much trying to design a study now. There have been very few papers out there relating to Sonata and adeno, 2 case reports with very limited follow-up, and 1 small case series that amounted to 12 patients with follow-up anywhere from 3 to 6 months afterwards. So we need more robust studies all around to really be able to say anything meaningful. But the outcomes so far seem to be good. Just the follow-up is not very long, unfortunately.
Thank you, Dr. Tobe. Well, I don't have any other questions in the chat. Last call. And if not, any other closing comments from our faculty? And if not, Dr. Hansen-Linder, I'm sorry, let me give you just if anything else you'd like to say before we sign off for the evening.
No, but I'm certainly always happy to review any cases for patients who are interested in pursuing pregnancy. If you feel uncertain about offering it to a patient, but wonder if it's an appropriate procedure, there's always those of us that are happy to collaborate and discuss it more with you.
Terrific. Thank you, Dr. Hansen-Linder. And thank you, Dr. Tobe, for presenting your information with us this evening. On behalf of Gynesonics, of course, Dr. Tobe and Dr. Leslie Hansen-Linder, I want to thank you all for joining us this evening. We're glad that you were with us, and we look forward to bringing you our next education webinar in the weeks to come. Everyone have a great evening. And again, thank you for joining us.